Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric OKelly. This week, we are with Michael Templeton, who is a flight paramedic for International SOS. Michael, welcome to the program.
Oh, thank you, Aebhric.
So tell us a bit about yourself and what's keeping you busy.
Okay. I'm a flight paramedic for International SOS. I've been on my current assignment for a little over 6.5 years. I work in the Cooperative Republic of Guyana at Eugene Correa International Airport. I'm assigned to a LIMSAR, or Limited Search and Rescue Oil and Gas Platform and Medevac service. My background in EMS started in the NHS in the UK, the National Health Service. Began there in a vocational route before going into the educational direction over 20 years ago when the foundation degrees were a new thing. And then probably about 14, 15 years ago, I ventured more into the private sector and started working away with my first assignment with International SOS in 2010. And between that time and now, I've worked for a few other providers, but the majority of my time since leaving the National Health Service has actually been with International SOS. I had to sit and count back how many years it's been. So that's me predominantly.
We met in Malta. What course were you taking at the time?
Yeah. So I took the TEMS and the Advanced TEMS course about 2.5 years ago. And I don't know if you remember, I actually communicated with you when before the college or the foundation was set up. You were providing training from Ireland, and I communicated with you probably about a dozen years ago or more, but never got to get over to Ireland. And then as the foundation set up, you were developing these TEMS courses for the tropics, which had an element of prolonged field care, and I was quite interested in that. So before the outset of COVID and the restrictions on flying, I actually came to meet you and see the school in Pretty Bay, and that convinced me I wanted to come back. So the following year, planned the time off around work, planned the travel, and happily took that program and got to meet some very interesting people. And in fact, a few of the people I stayed in regular contact with, and two of them from my cohort I'm in certainly weekly contact with. So it was a fantastic program.
Nice. And the tropical medicine you learned, have you used that knowledge?
Clinically, not so much, because my role is somewhat limited in that application. However, it is still useful because it's given me, I have worked in a tropical environment in the past, and it's given me a little bit more wider scope, not scope of practice, but understanding. And when I receive patients who've had issues in the past, it gives me a little bit more sort of to look into an appreciation of what's going on. So whilst directly I've not been able to do any of the blood work or the microscopy, I still think it's been valuable because it's the program was invigorating in its own way.
Nice. So tell us what a typical day is for you as a paramedic working for ISOS.
Okay, well, days change a little bit, but generally Um, so I would be based in an apartment. I live by the airport. So I have to be minutes away from where the aircraft launches from. So that restricts a lot of my movement, and I'm not particularly free. So when you come on duty for your rotation, you're not as free. And that's something that people who've never been on these jobs before don't appreciate. They think that when you go to these countries, it's like being on holiday. And the moment you go to the airport to check in your bag, you're on work time and everything is for that purpose. So wake up in the morning. Some people wake up earlier to get exercise in before the sun comes up because it's a hot country. Normally meetings, so briefings, weather briefings, um, safety briefings will normally begin around 8 a.m. on a Monday to Friday, and it gets pushed back an hour on a weekend. Those briefings tell you like what's going on with commercial traffic. We need to know, obviously, if there's any restrictions. For example, the military might be doing parachuting. There may be a U.S. warship nearby with live firing, so we need to be aware of their position and if that would affect us. Generally, the weather, and then any plans for the day. So maybe there'll be visitors coming. There may be site audits or inspections. There may be flight training or med training, or there may be some. Uh, we have like I'm trying to think of the right word. Like I'm going to say an EMS meeting, but it's clinical governance. We might have a clinical governance meeting going on. So your key relationships would generally be flight crew, safety, and sort of medical management and resource. Then, as part of the morning routine, check your equipment, do your stock checks. That takes just a little bit of time. Just verify you know where everything is. And then from there, it's either whatever meeting or training is scheduled for the day, or if you're on a call out, you attend that. And that's pretty much the routine for the day. Generally, things quieten down after 2 p.m. When commercial traffic lands. And between 2 and 4, maybe there's a last chance of a call out because they want to get someone off maybe a vessel before the nighttime starts. Nighttime flying is limited as much as possible for safety. So, and then the day would repeat the following day.
So, how many medics are there with you in Guyana?
As a flight paramedic, there's only one on duty at any time. So generally, there's two of us back to back. There are other medical staff, ground staff, there's hospital staff, and some of the vessels will have medical staff. Many of the places, people in the interior or some of the air crew will have some form of first aid training, but it is really first aid or basic life support training to assist. But unless they're a doctor, nurse, on board somewhere, there is nobody else. It is just a paramedic.
And you're in Georgetown, right on the water?
Yeah, very near Georgetown, in Greater Georgetown. I'm in a region called Ogle. So there's the Eugene Correa International Airport there, which is actually the busiest airport in the country, despite its size, because it has all the oil and gas flights. It has the commercial traffic going to the interior and to places like Venezuela, Suriname, Brazil, and Trinidad. So it gets very, very busy there, busier than the large airport, let's say, which has the heavy jets arrive.
Yeah, I'm pulling it up on Google Maps. It's a single strip, isn't it? It's really small.
Yes, but it's actually reasonably long. They can probably extend it by another 100 meters without getting myself into trouble when this is broadcast. there's houses at both ends, which limits its extension. Um, so you can take off in a Cessna Citation, which is a small jet airplane. So a Cessna Citation kitted as a air ambulance would be able to make the run. But something like one of the larger Lear jets would have trouble. It's not so much the landing, it's the takeoff because of the abort limits on the runway length.
So, what kind of training did you need for this job?
Oh, that's interesting. I've met a few other people in International SOS, and we've all come by various different routes. So but mine's not the only way to get into this realm. But mine was, I did the foundation degree with Hertfordshire when it was new. I then went later and I did a separate Bachelor of Science in Ireland, in Limerick. And just over time before getting into this role, I was trying to aim toward sort of the offshore and aeromedical. So I took a postgraduate award in special incident management, and then later the postgraduate diploma in remote and offshore medicine from the Royal College of Surgeons of Edinburgh.
Nice.
In terms of practical training, I did rope rescue and propel in Sierra Leone, and then did my supervisor's course in Wales, and then did my sort of aviation. So for Europe, you got to comply with JAROPS 3 standards. So I did my aviation for flight medical crew, helicopter medical crew in UK. So that's communication, navigation, meteorology. It's just very basic. It's not to the air crew standard. It's just that you can basically navigate, you can call for help, and you know when the weather looks bad, and you can point to the pilot and say, "Look, I think that big storm cloud's going to hit us." In terms of hoisting, I actually went and did a HEMS course in Australia. So I went to the academy, which was then in Queensland. It's now been taken over by Life Flight, but it was then Care Flight. So trained on 412s. Then I got exposure in Papua New Guinea on BK 117s, and then finished my what the Australians call their TAFE Cert 3 as rescue crewman, and my back-to-back has got his Cert 4 from the same institution. So we needed to have those in order to work in a rescue capacity for our different contracts, even though we were employed by International SOS. So that then gave us the basic the package to present us as flight paramedics. But we're both also FPC certified. I took mine in 2014, and although it wasn't a requirement, it was hinted that it should be maintained. So I think that's valuable to add in as well, that the FPC, and not just doing the exam, but trying to get as much practice in those skills. There's many of those skills that are impossible to keep up as a paramedic. So try to get as many of them in as you can, and as exposure as you can. It does help.
So, what preparation would you recommend for someone wanting to get a job like yours?
Well, first, I would highly recommend working for a busy EMS anywhere, particularly in an urban setting for a year, 2 years. You've got to be able to be confident, and because you're going to liaise with doctors, nurses, safety, and you have to be able not to be a bully, but be a leader. Sometimes when you turn up, people will just stop doing things and just expect you to take over and rescue them. And other times you've got to slow people down, and you need the confidence to know when to move quickly and when to move cautiously. And I think that EMS is a good basis for that. So working a quiet station in a rural setting just won't give you that. So I think that's a real fundamental. And to get out of the clinics as well, you've got to be used to pulling stuff out of your bag and going without certain bits of equipment and not having the full diagnostic suite that you would have in a clinic or a hospital. So that's I think a big one. In terms of treating patients on their own, anything that you read in aviation is going to be a big plus. It also depends on, are you strictly medical or are you going to be doing rescue? If it's purely medical, then sort of advanced care stuff and getting further exposure, definitely taking something like an FPC or a critical care paramedic exam. But that in itself, you need to go somewhere where you're going to get a little bit of exposure or allowed to do stuff. If you're going to go down the rescue route, I think anywhere that gives you that exposure. So you can volunteer for the Coast Guard because they will have rescue. You can do stuff with the fire service. Much of, even though there's different techniques and different equipment, much of the sort of processes are very similar and replicatable. So if you've learned it in, let's say, the fire service or from the Coast Guard, or even being out on a boat, that I think raises your awareness and puts your head above the parapet. And I think anything that you do on your own and not expect the employer to present to you further raises your head above the parapet that you've done something interesting. And do you know what? Just the type of person you are, you've got to want to be the one who gets in there. So present that as a character trait. You know, do you go walking in the mountains on your own? Do you like camping? Do you know, these aren't necessarily vital skills on their own, but I do think it does highlight. One of my colleagues from Britain, he started out in Cambridge. He's a mountain leader. One of my other colleagues is a wilderness firefighter. So, and I think they do this on their own time. So I think this raises an individual's profile a little bit. So just seek any opportunity to volunteer and do. But I do recommend the FPCs, and I do recommend working for a busy EMS to get that basic, just to get those basic core skills tied down.
We send our bachelor's paramedic students to KCMC in Tanzania. They're seeing 70 to 80 patients in a shift, and they're just getting tons and tons of repetition.
Yeah, that's it. The basic skills have got to be fairly solid, and you've got to be put in a position where, even though you're working to protocols or to certain standards, and each region will have their own protocols, you have to make decisions. And very much in a lot of these jobs, it's less than an ideal situation, and a paramedic will have to decide, do I intervene or do I not intervene? Is this going to go down on me, or do I intervene and then risk doing more damage? And you're not in a position always to have someone else make that decision for you. So I do think, busyness, those at least a couple of years, gives you that thorough grounding, because you'll get that patient exposure. So Tanzania would be great. Anywhere where you're working.
And you mentioned postgraduate degrees. You've got a few postgraduate programs under your belt. You mentioned another postgraduate program from a colleague you had. How important is that?
I don't think in and themselves they're important, but I do think that they do help. So let me put it another way. When dealing with sort of longer term cases, how you'll manage them. For example, in the UK and certainly in the United States, and I suspect for most of Europe, there's a pretty well-established protocol for things like STEMIs, or what you'll do for a PE. But when you're working in different regions, many of these established means are not there, and then it changes because the person will not receive definitive care, sometimes hours or many, many hours. So, what will you put in? And I think that the graduate and postgraduate level education allows you not just to replicate, but to sort of argue and present a case to your employer and to the clinical governance group, why you should do something, why you should not do something. So I advocated for the introduction of Penthrox. Where we are, it's not realistic or feasible to carry Entonox. So we needed some type of analgesia that could work with or without or in adjunct to opioids. But then how do we give opioids? Are we going to give it IV, IM, etc., IO? What can we do? Will this work? And there was a lot of pushback in the beginning about renal toxicity. But that was based upon it being an anesthetic and not as an analgesic. So I put together a 5-page document with the evidence and where it's been introduced under what licenses to argue for it to be an analgesia. And it was accepted. So I think that's where the sort of graduate level stuff comes in. Rather than copying and pasting something, you can then present an idea and then have it push forward.
Yeah, I agree with you completely that undergraduate training is fantastic for getting the basics down, but postgraduate starts getting you thinking of the bigger picture.
Mm-hmm. Yeah, for sure. So, in terms of postgraduate, I have a postgraduate award, postgraduate diploma, and a master's degree. And like yourself, I like to follow in on the PhD or professional doctorate, but we'll see how that goes.
How safe is it in Guyana?
Um, I mean, there's risks. You know, um, Foreigners can easily be robbed. Um, RTCs are a huge risk. There is crime, but then, like all things, there's mitigations. So I don't go to certain places in town where crime may be. And even if I go to town, I tend to be with somebody who's one of our employees, and they're tasked me as a driver. Because of the risk of driving, our company has a blanket policy that expatriates are forbidden from driving. So we have to be driven. This also prevents claims from to our company and to our client company, the big exploration and producer in oil, for people seeking compensation. So these are all realistic mitigations, and going about to places where crime may be, we would just tend to avoid those areas. If you need to meet people for a meeting, it would generally be done in an office or a hotel sort of restaurant. And again, going out to eat, it would be well established places, and cars would be selected according to their safety standards. So we're forbidden from getting into sort of dodgy taxis or anything. So we mitigate the risk as much as possible. So generally, I think it's safe in terms of flora and fauna. Again, very similar. There are snake risks. We've seen a number of poisonous snakes, or venomous snakes. I shouldn't say poisonous, venomous snakes. I remember one of your lectures on that, distinguishing between poison and venom. Right. Yeah. And but again, these are mitigated where you're told where to walk, what footwear you wear, where you're not to stand, where you're not allowed to put your arms. So it's all very simple stuff. Even things such as malaria risk is very well mitigated. So it's it's as safe can be. But remember that, you know, going on a deck on a boat, you're dangling from a 4 centimeter steel cable on a hook onto a moving ship. I mean, that in itself is dangerous, but it's as safe as it can be. So, things are mitigated as much as they can be.
And you've had some PFC experiences as well. Tell us about that.
Um, well, the one that pops to mind. So, last year there was a crash, an aircraft crash in one of the regions in Guyana. It was a government aircraft, and although it's outside of our sort of scope because we serve a private sector, the client was asked if they would allow their resource to be tasked to that. And their resource is the rescue helicopter. So we were tasked on that. And the first day we couldn't find them. We actually launched very late. It was quite a big distance. And then we went out searching the next day and they were found in the afternoon. So we inserted in the afternoon. And sadly, most of the people in the aircraft were killed outright, but there were two survivors with injuries. And because of weather and cloud base, the rescue helicopter had to leave scene. And I had two injured people in the jungle overnight. One of the injuries, it wasn't so severe, but it was burns over a large surface area, but not deep burns, and that was caused by the kerosene fuel. And the other person had what appeared to be a neck injury, but the impact, the aircraft basically was torn to pieces, and the impact had killed 5 others. So the precaution was that this person had a neck injury, but on the ground with a bag of limited gear because I'm only anticipating being on the deck for about 10 minutes. So there's no scooping anybody, there's no vacuum mattress, there's no you know, manual inline stabilization. That's all gone. So making do with what they had to protect this person, and then making a plan to get them out when another aircraft could come the following day.
So, how long did you have them?
Probably, I would say about 15 hours.
Wow.
So the original plan was about a 10-minute sort of go and grab them. And when it's in a rescue situation, we tend to ignore injury because it's better to get them to the aircraft, even if they're injured, than it is to leave them behind and do nothing. So very different than what people see on television HEMS, where the person's carefully boarded or put onto a scoop, the aircraft lands and switches off. You're probably about 1,500 feet up a mountain, with the helicopter hovering a good couple of 100 feet above the trees, and it's a cable, and obviously they're limited for fuel and weight and range. So that is part of your calculus. Like, how long do I have? There is an expression that comes from U.S. military and out of Cougar helicopters. You ask your pilot and your basically crew chief, hoist operator, for your bingo time. Basically, how long do I have before you make the decision for fuel? And they will give it to you in minutes. If they have lots of fuel, they'll say, you have 40 minutes and that's it, we're gone. Not 40 minutes and then we'll tell you we're leaving in 5 or 10. That is it. And very often on that sort of mission, your bingo time is 10, 12 minutes before they make the decision. But while we were there, there was, as I said, cloud rolled in. That makes it unsafe for the aircraft, and the aircraft was forced to depart before they lost their exit. Otherwise, that puts the aircraft at risk, and the aircraft must take priority over the injured.
So you spent the night with him, and how did you manage ins and outs? How did you manage the nursing care?
Okay, so with the burns, I dry bandaged him. I just cleaned his back and then dry bandaged him, and limited for pain relief. I didn't have any sort of oral analgesia. I only had things like ketamine, morphine, fentanyl, midazolam with me. That was a bit overkill, and he was terrified of needles despite the ordeal he'd been through. So we said, "Look, we'll give you something. We'll give you something if it hurts too much, but you let me know." So just try to make him comfortable. With the young man with the neck injury, tried to keep him stable and tried to make an improvised sort of collar using, I think I used a SAM splint, but it was folded down, and it wasn't intended to stop his neck moving. It was more of a case to remind him not to move. Laying him down on the ground would not have helped because we would never got neutral alignment with him because it's all lumpy and full of bits of roots and other things on the surface. The military had hiked up, so the military had special forces of Guyana had abseiled in further down to secure the crash site, retrieve the black box, and secure the deceased, because these were the highest ranking military commanders of the Guyanese military who were killed. So one of them had a hammock, so took the hammock from him and put the injured in the hammock, because it was more neutral aligned and less pressure on his back. And then once he was down, removed the SAM splint and just used his coat and clothing just to pad him out, just to remind him to keep still. Moving him, tried to use his body to keep seated. So we sit his legs and then guide him back, trying to achieve as much neutral alignment as possible, but it will never be perfect. But also, there was a study done by the Naval Defense Naval Medicine in Gosport, Hampshire, and they looked at secondary assaults, particularly for soldiers who were serving in Afghanistan. And after, the concern was, how do they move soldiers who are suspected to have neck and head injuries, who were in combat conditions? And they came to the conclusion that the likeliness of significant injury of secondary assault was so minimal, it wasn't worth it. If the person had received a significant injury, it was done in the initial assault. That doesn't mean don't care for them or limit the secondary assault, but there is some degree of movement achievable if it's for the person's greater safety. And in instances of combat, what this study was particularly looking at was soldiers who were injured and unconscious. To maintain their airway, could their buddies roll them over, even though there may be a suspected neck injury or head injury, and to protect their airway from aspiration, that was deemed acceptable. So with that sort of background, I thought, well, I'm mitigating any further damage. So yeah, went with that.
Nice. And then they finally sent in aircraft to collect you the next day.
Yeah, so a government 412 was fitted with a hoist, and their people underwent a 20-minute crash course in hoisting by the civilian staff who were ex-Royal Navy. Um, they had never hoisted people before. That became very evident, but I won't criticize. The reason for the other aircraft was that the large rescue aircraft is like a sideways windmill blowing at hurricane speed. Um, it will knock down the trees, it will damage the aircraft's crash scene. Um, so they needed a smaller aircraft to achieve that. But there were hazards and risks involved there, and the crew had never done it before. So there was inherent risks there, but it was used to get the injured out, to lift, uh, got myself out, and then later a plan was used to lift the deceased out, and then the small detachment of special forces who'd come in as well.
And you were injured as well.
Yeah, um, yeah, it's quite sillily, but yeah, I on the day that I got in there, um, I put my leg through some dead material and dislocated my knee laterally and tore three ligaments. I realized I'd done some damage. At first, I thought I tore my meniscus, withdrew my leg, and thought, oh, I've done some damage. And then I tried hiding it so no one would notice that the rescuer himself was injured. But the following day, after I came out the jungle, it was apparent. People could see that I had a stiff leg because the muscle all started doing its stiffening. And even when I got back to the airport and people saw I was injured, it wasn't apparent how serious it was. And then, some days later, MRIs revealed that there was significant damage. And then a couple months later, I had further MRIs that looked at it in detail, and the surgeon was able to show me on a model how my knee dislocated, and that was causing problems. So it took some months to rehabilitate, but I'm back to duty, so all's good.
Wow, that's rough. You also had to deal with Ebola in Sierra Leone. Tell us about that.
Yeah. Well, so I was there with a company that did um, basically the contract company or the client was there for iron ore, and there was a special EMS section, and the EMS section did two fundamental roles. One was, well, I'll say three. One was to provide sort of immediate first response, clinical, and um, uh, also runs clinics for your sick parade of the workers. The next was to provide a fire service, so there were uh, trained fire personnel there with different fire appliances, and locally employed staff who would be used as firefighters. And there was a technical rescue team as well. So during that period, when Ebola started, I got a call one morning from the superintendent of EMS, and there's different camps located throughout the country according to the task that their site is responsible for. And it was probably around 7 in the morning, and he said, "Michael, what do you know about hemorrhagic fever?" I said, "Very little, superficial." Why? He says, "Well, can you do a briefing on it?" I said, "Yeah, no problem." But obviously, we had the morning tasks. You do the sick parade. Then we had rescue training. Then we had fire drills. And he calls me up and says, "Well, I need this document." I said, "Well, I'm on the training that you've required of us to do." He says, "Well, can you do it in an hour?" I said, "It's going to be done in an hour." So I said, "Okay, I'll work on it this afternoon." So I started putting some stuff together. And he basically says, "I need a document that says how we would react to a hemorrhagic fever." Again, I had no idea what was going on. So I put it together as a hemorrhagic fever thing, how to approach it, how to clean, the 7 moments of hygiene, all this stuff. And then he says, look, I specifically want you to aim toward Ebola. Okay, we'll do Ebola. I said, well, I need to be let off duties tomorrow. I can't do all. So he said, yeah, let off duties, but please do it as quickly as possible. And I put together probably a 20-page document in a day or so on how we would approach hemorrhagic fever clinically, send it off to them. And what I didn't realize at the time was Ebola had been discovered, and the management had approached the medical director, said, what is our protocol for dealing with hemorrhagic fever? And she turned to the head of EMS, and he looked on the shelf and found there was no policy, and then realized there was someone that was trained in health emergency planning. So called me up and just said, fix it. And so I came up with that. And then when we realized that this was now spreading and the public weren't really aware, we needed to mitigate the risks to our own staff. And one of the most important things you can do to inactivate the virus is to expose it to chlorine. So I went down to the local town and cleared the shelves of chlorine bleach, because I knew that we would soon not be able to get supplies. And I didn't realize later how quickly the international flights would stop, but chlorine bleach and other cleaning products were going to fly off the shelves, and they did. So I secured as much as I could, and the other sites did the same. Then as the disease started progressing, some of our local hospitals, a number of nurses started dropping dead. And we had to not go there because it can take a couple of weeks before you get symptoms and you're contagion during that period. So we instituted a policy that nobody entered our camp unless they were temperature screened, and they walked through a bleach bath. We then washed and bleached wheels of vehicles. Local staff had to have their temperature checked outside. If they had a low-grade fever, they were refused entry for 3 weeks. And it sounds pretty cruel, but the disease would take hold in 3 weeks, or they didn't have it. And in the early phases of the disease outbreak, the chance of surviving it with minimal treatment was less than 10%. And by the time international agencies came in and brought in treatments, treatment was successful 50% of the time, and it was effectively supportive therapy. But the risk to the healthcare provider was extreme, so they had to wear double protection, really scrubbed up, taped seals, complete isolation, and then the same, they then had to go through a decontamination process and removal in an appropriate order to prevent them from getting the Ebola. So this put a lot of stress on health workers, and a lot of the local hospitals, either through ignorance or willful wishing, chose not to do this. And when Ebola comes in on one person, it spread through the hospital like wildfire. And one hospital in particular was actually a Swiss charitable hospital in a place called Bincolo. And it killed a lot of the nurses, and the hospital sadly had to close during that period.
Wow.
Yeah.
That's rough. How long were you engaged in that response?
Oh my goodness. Well, that went on for, that started early 2014. And I went, after a number of months being there, I went out the country. And then because of contracts and other risks, and it's not to do strictly with Ebola, it was also to do with finances. Expatriates were asked not to come back in but many expatriates were asking to leave early because they feared getting the disease, and many international carriers had shut. And trying to get out, I had to be routed through different places in Africa to get back to Europe. And then I was stopped at Heathrow and detained there for a few hours because, they found out where I'd been. But I was completely clear. And then I went back a few months later on a UN mission, but with a private company. We were a specialist medical flight crew to bring out the people who had illnesses other than Ebola and get them to definitive care that could be flown further away. So we avoided any region where Ebola was because there was international agencies dealing with that, but there were people who still had normal illnesses who had to still be treated and get access to hospital, and there was a UN facility established and set up, and much of our time was spent trying to support them and give them advanced life support training because many of the staff there had never done it before. So that was actually quite a good experience.
Wow! So you've had quite a few interesting things that you've been part of.
Yeah, it's interesting. I think you and I have spoken offline before. We meet people, and I know that with the faculty, there's a number of guys there done some fantastic expeditions and other things, and we both know somebody who's done training in various places, and we know somebody who's worked in northern Iraq and seen all the things that have evolved there over the last dozen plus years. I rather thought my role was kind of boring, but when I sit back and look at it, I'm glad for the opportunities I've had, but mostly for the people I've got to meet along the way.
That's fantastic. Michael, my final question for you is this. What advice do you have for the new medic, the new nurse, the new doc who is just starting out on their career in austere medicine?
Okay. So they're already hired by somebody. First off, first to the doctors. This is going to sound rather pretentious, but bear with me, please, listener. To the young doctor who's, whether they're a graduate or they've done a few years specialty training, they are the medical provider, and the doctor can never leave a patient. But that's what goes with the big dollars, I guess. So the doctor always gets the worst case. But also, they don't know everything, and be willing to listen to people, even non-clinical people. Your drivers know things, and they know how to approach things, and many of them know how to apply stretchers, which the doctors don't. The nurses know a lot of procedures, and there is a myriad and a minefield of litigation and legislation in every region, even if we think it's not up to date or first world standard. You need to trust your nurses for that because they will bail you out. And regarding paramedics, if you've never worked outside of hospital before, trust your paramedics and let them lead. They're not there to show you up, but many of the times what you think is appropriate to do medically is not functionally or operationally appropriate. For example, where I work, I have to consider the aircraft crew more than the patient. We have to consider fuel. We have to consider where we are, and are there any other dangers. So that is a huge consideration. And paramedics who have worked EMS will have this instinctively built into their sort of first, their primary survey. For the nurses, I really don't know. Much of their work predominantly is sort of clinic-based or administrative-based. Very often it's far more administrative than they would like. It's part of the task because these jobs have to be done. And for the paramedic, it can be quite frustrating. Have an open mind. You may be limited in some ways, things, and you go to countries where they don't have paramedics, or their concept of a paramedic is somebody who's got a first aid certificate and can put a band-aid on. So you want to prove yourself, but you don't want to be cocky. Make friends, particularly for the paramedic on small sites. First friend to make is health and safety. They are the people who will always, who can get you out of all sorts of things, and they can make things happen. So health and safety is your friend. They do have a job to do, but you need to be on side with them and get on well with them. If you're in a place where there's a security risk, also make friends with the security manager, understand their side, understand what they're dealing with, and they can support you a lot. If you're on a very remote site, make friends with the chef. My goodness, can they give you everything? And, they look after you, you look after them. So go with it. And for the paramedics as well, be willing to learn stuff that's not paramedical. You're a bit of a jack of all trades, particularly if you're on a small site or you're alone or it's just yourself and maybe 50 guys or girls. You may be asked to do water testing. Do it with good humor. You're going to go out in the jungle. It's miserable. It's wet, whatever. You got to walk on certain paths to avoid snakes. Just do it. You may be asked to learn something about different medications that you'll give because of gas coming off. You'll be given special training for this if it's a petrochemical site. If there's security risks, you'll get briefings for this. Learn about this. Be willing to go on courses for hazardous environment. Also, be willing to look further and maybe take a health and safety course so you can understand mitigations. It really is a big part of it. So don't just do purely paramedic roles. Be willing to look out sideways. And, if you're in an aviation environment, learn what goes on flying, take a flying course. Even a simple sort of medic flight crew course. And many employers, if you've proved your worth after a short time, sometimes 6 months to a year, they're happy to pay for this because they get something back in kind. I would also, you can look at your prolonged field care. This gives you a bit of, it's like an insurance policy. You may not get to use it, but it gives you a sense of confidence. And where you can practice a skill, you're never going to master all of them, particularly working in some of these places. But if you're working in a malaria environment, learn about malaria, learn how to recognize it, learn about preparing a thick and thin film and how to recognize it under microscopy and how to count them. This alone puts you ahead of 90% of paramedics. And there are short courses you can do to do this. And I think through the foundation, I might be wrong, but there's also a new tropical course that encompasses this.
That's right.
Yeah.
Yep.
Because I'm interested in that, because it's quite difficult to get on the medical tropical courses. So again, that's something worth of the repertoire to extend out. Don't just be a paramedic, is basically what I'm saying.
That's good advice. Thanks for talking to us about your experiences, and I look forward to seeing you again in Malta.
Oh, thank you, Aebhric. I look forward to coming back. Thank you for your time.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.